So this morning I'm going to speak about the very common symptoms, but not as much discussed symptoms of Parkinson's disease, what we call the non-motor symptoms of Parkinson's. So we all know Parkinson's disease as the tremors, the stiffness, the slowness. But in addition to that, almost all of you know that in addition to these motor symptoms, there's a lot of non-motor symptoms. So symptoms related to mood, related to sleep, related to the constipation, digestion. So this is the focus of what we're going to discuss today. So these symptoms even happen before you start having the motor symptoms. As you can see here in this graph, if you look at this graph, whatever is in green is these non-motor symptoms of Parkinson's disease, and whatever is in teal blue is the motor symptoms. When you go to the doctor, we focus mainly on these teal blue symptoms initially. But if you look at the number of symptoms, there are much more non-motor symptoms, and they can happen many years before you start having the symptoms of motor symptoms of Parkinson's disease. So you can have sleep problems, you can have constipation, depression, anxiety, even before you know that you have Parkinson's disease, and then these symptoms can continue after. So some of you might ask is that many people with Parkinson's are older, and then with age, some symptoms tend to happen. So you have sleep problems with age. You can have urine control problems with age. So is this just aging? In Parkinson's disease, these symptoms appear to be more frequent than just with aging. So they did a study, and then they observed the number of these non-motor symptoms in two groups of people, one group with Parkinson's disease and another same age but without Parkinson's disease. And then the number of these non-motor symptoms in the group without Parkinson's disease is on average 3.5, whereas that in Parkinson's disease is 8.3. So it's a significant increase in number of these non-motor symptoms, indicating that it's related to Parkinson's disease and not just aging symptoms. And as I said, many of them can happen many, many years before. So some of them happen even more than 10 years before you would present the first signs of Parkinson's in terms of tremors or stiffness or change in walking. So some of the earliest ones would be, for example, change in sleep, change in mood, or acting up dreams. These can happen many years before Parkinson's even starts presenting physically. Also, there is a difference in how old was the person when they started having Parkinson's. So if there are certain non-motor symptoms that are more common in younger people with Parkinson's than in older people with Parkinson's. And also, the longer you have Parkinson's, the more non-motor symptoms you tend to have. Now, there is controversy about if there's any effect of sex or effect of ethnicity on these symptoms. There are some studies that show that men have a higher incidence of sexual non-motor symptoms. Women have a higher number of mood or sleep or dizziness non-motor symptoms, but that varies a lot. So it is not something that's very clear right now if there's any sex difference in these non-motor symptoms. And also the same thing with ethnicity, there's not a lot of information there. One study showed that constipation may be more common in Asian and Middle Eastern populations, but that's not very clear at this point. Another thing that is present in non-motor symptoms is something that a lot of people with Parkinson's disease know, which is something called fluctuations. So your day-to-day function with Parkinson's disease varies. So you have good times, bad times. You have sometimes the medication is working, other times the medications are not working. Sometimes the tremor is there, sometimes it's gone. Same thing with these non-motor symptoms. They are not always present at the same level all the time. So anxiety can come and go. A lot of people have something called internal shaking, which we really don't understand very well. We think it's related to anxiety, but we don't really understand it very well. Pain can come and go. Urinary symptoms also can come and go, lightheadedness. So these things are not static. They change through the day and from day to day. So let's start with some of them. So decreased sense of smell is very common in Parkinson's disease. Around 90% of people with Parkinson's disease will have a decrease in sense of smell over the duration of the disease. And having a decrease in sense of smell can happen before you have the motor symptoms of Parkinson's disease, and there's a 10% chance, so 1 out of 10 people who have a decrease in sense of smell end up developing Parkinson's disease. But it's not specific, so not everybody who has decrease in sense of smell will develop Parkinson's. That could be related to sinus disease, could be related to smoking, could be related to other conditions too. The reason we are interested in knowing sense of smell is for two things. First, it's very important for us to taste food and enjoy food. So if your sense of smell has decreased significantly, everything tastes metallic or doesn't taste right, and that can decrease your appetite and have some health complications. And then in addition to this, for safety, most importantly, gas leaks. You might not be capable of smelling the gas leaks, so it's very important to evaluate that and make sure that alarm systems are updated and the batteries are working, just because the sense of smell might not be as acute to smell a gas leak, for example. Now these are the areas we're going to speak about. We're going to start with the cognitive changes or the thinking changes and memory, and then we're going to discuss some other portions of the body. Okay, so for cognitive changes or memory changes, this is common, but it increases with disease duration. So the longer you live with Parkinson's disease, the higher the chances of having cognitive changes. And in Parkinson's disease, there are two forms of cognitive changes. There's something called mild cognitive impairment. You hear your doctor saying MCI, mild cognitive impairment. That's not dementia, that's having some difficulties that you didn't have before, but you're still independent, you don't have meet criteria for dementia. This can progress to dementia, called Parkinson's disease dementia, but doesn't have to. And the rate of progression is between 9 to 15% a year. And as I said, the longer you live with Parkinson's, the higher the chance of having dementia. So at 3 years of having Parkinson's disease, the risk is 10%. But at 20 years, the risk is 83% of having Parkinson's dementia. And as you would expect, having memory changes or cognitive changes is going to be associated with difficulties in day-to-day life and decreasing quality of life, as well as caregiver strain at the time. Now, there are some features that can help us know if a person is at higher risk of having cognitive decline. One of them, for example, is having early visual spatial deficits, so having early difficulties with assessing depth, assessing relationships in space, getting lost in a big supermarket. Having these early on in Parkinson's increases the risk of developing dementia later on. And the cognitive changes in Parkinson's are many. Almost all the functions can be affected, but the one that's usually spared is language. So language in Parkinson's disease, unlike, let's say, Alzheimer's dementia, is usually not affected, at least in the beginning stages. Now, in very advanced dementia, it can start to be affected, but the characteristic feature of Parkinson's disease dementia is that the language is usually spared, but there is involvement of something called frontal functions. So these are the functions that allow you to synthesize information, and mainly usually complex information, and try to create or deduce a plan or something to do with that information. Attention is also very commonly affected and early on in Parkinson's. So this is one test that when you go to the doctors or when your doctor sends you for memory testing, this is called the Tower of London test. If you look here, you would see two panels of stacks. There is one here that you need to emulate by moving the piles here. So this is what you need to do. This is what you're given. So what you need to do here is move the red here, then move the green here. Now this is simple. This test keeps going, increasing in difficulty. So we're doing, and this is an example of this frontal test. So these are executive functioning tests. This one is a bit complicated, so you can see that this will help you know at what level you're having difficulty, and that can allow you to determine how these cognitive changes are changing. So in In the beginning, you might do all of these right, then let's say 5 years down the road, the cognitive changes worsen, and then you might have a decrease, and then you might miss the last one. So that can allow the doctors and you to know how your cognitive changes are changing. This is one test. Usually you do a big battery of tests to find out these changes. So we spoke that there are risk factors that increase the risk of cognitive change. One of them is this visual spatial deficit, but also being older with Parkinson's increases. The cutoff is around 70 years of age, so people older than 70 years of age with Parkinson's tend to have a higher risk of having cognitive changes. Having no tremor as part of the Parkinson's disease can increase the risk of changes, of memory changes, decreased sense of smell, acting up dreams, having depression, and having hallucinations early on can also increase the risk of these memory changes. So what do we do in these cases? There are certain things you can do at home. Some of them are exercise. Exercise is important for cognition. We know that not just in Parkinson's disease, but we know that in all forms of memory problems or dementias like Alzheimer's disease. We know most of the evidence is for aerobic exercise, so like running, biking, swimming, but also resistance training seems to have a role too in there. The other thing is something called cognitive training, which are these groups of computer or pencil puzzles that you do and that can help. So some of them you can buy as a service, and others you can just buy a booklet and then do it on your own. There's not a lot of studies to back these things, but they have very low risk and possible benefits. So we usually recommend them to our patients as something to do in terms of cognitive training. Now, in terms of medications, the only medications we have are for Parkinson's disease dementia. We don't have medications for this milder form called MCI, or mild cognitive impairment. The only FDA-approved medication is called rivastigmine, or the brand name is called Exelon. Other commonly used agents, though, are donepezil. We use it very commonly, but it's not FDA-approved. Another one is memantine, also galantamine, and there are some other agents that your doctor might use with you. Now, the medications that we commonly use to treat Parkinson's, the levodopa, dopamine agonist medications, can help cognition early in the disease. So many people, when they're early in Parkinson's disease, they take the levodopa, they feel that their thinking is better, their attention is better, but then as the disease progresses, this benefit of dopamine on cognition wears out. It doesn't stay, and then sometimes these medications can worsen cognition, and that would be something that you and your doctor would decide the balance between controlling your tremor, controlling your stiffness, and possibly worsening your cognition as you reach the stage of advanced Parkinson's disease. And there are other treatments that are being developed that are non-medications, so stimulation by electricity, whether it is deep brain stimulation as well as non-invasive like transcranial magnetic stimulation for memory problems and Parkinson's disease. We all know about DBS for Parkinson's disease motor symptoms, but for the non-motor symptoms, there is also work in that too. Okay, the other thing that usually comes with these cognitive changes is something called psychosis. Anybody has heard of the term psychosis just by raising hands? Okay. So psychosis is a general term that means separation from reality, and that can be from multiple ways. It can be in form of hallucinations, which is seeing, hearing, or feeling things that are not there. They can be simple or more complex. And they can be delusions, which is having thoughts that are not based on any real evidence. So paranoid delusions is the most common example. So if we look at this graph, the hallucinations in most people with Parkinson's, around 50% of people with Parkinson's, is simple, which means that they would have a feeling of a presence, like a person with Parkinson's would be sitting and feels that if there's a person behind them, they look behind them and there's nobody. That's a very common type of hallucination. Another one is a shadow hallucination. They feel a shadow passing on one side or the other. Another is seeing double of one thing, so they're watching a football game and the player becomes 2 for a second and then becomes 1 again. So that's another hallucination. And the last one is illusion, which is they see like a fire hydrant as being a raccoon for a while, and and they look away, they look back, and then they see it's a fire hydrant. So these are the milder forms of hallucinations. They're quite common in Parkinson's. They occur in around 50% of people. They are not as well associated with increased risk of any complications in terms of cognition as well as safety. Now, the ones that are more concerning for us when we see patients are the hallucinations that are well-formed, which means that they see a whole human or see a full animal that's interacting with them, and especially if they have difficulty in realizing that this is a hallucination, because they might act on that as hallucination, run out of the house in the middle of the night, get lost. So hallucinations by themselves are not a reason to be scared in general, unless there is a complication or a concern for safety or a concern for quality of life. In that case, we would like to treat them. So we're going to listen to this gentleman.
But there was a guy came out of my garage, and he was walking towards the car, and all of a sudden, he reduced out to, I think it was like a raccoon, and ran under the porch. That was the most bizarre one. There was a person coming out of the garage, coming towards the car, and all of a sudden, he just went from that to a raccoon, went under the porch.
So what was your feeling about that? I mean, that's
scared.
You were scared.
Yeah, I was scared.
And you were scared because these things were happening, or were you scared because you thought you were losing your mind?
Well, I thought possibly the two things. What was causing it was something was happening in my brain that I can't account for. And I was scared of the events that I was witnessing.
So you thought something bad might happen to you?
I did.
Okay, so if you didn't hear it, the patient saw initially a man coming out of the garage, and that man suddenly turned into a raccoon. So effectively, that's an example of an illusion, where the person is seeing a raccoon as a man, and then the raccoon will appear as a raccoon. It could be that this was completely a full hallucination. It's very hard to tell, where none of these two things were there at the time, whether the man or the raccoon, but this is an example of hallucination and how concerning it could be. You can feel, if that person felt there's somebody coming to his house, and then there was a raccoon at the end. So it could be very disturbing for the person as well as the people living with them in the home. So having psychosis, especially the well-formed hallucinations, not the milder forms, increases the risk of dementia, increases the concern for quality of life, as well as increases the risk for nursing home placement, just because of the difficulties of managing these hallucinations and the reactions to these hallucinations on a day-to-day basis if they're very frequent. Now, in terms of management of the psychosis, you try first of all to see if there's anything that might be inducing the psychosis. So any mood disorder that might be associated with Parkinson's. Take out all the medications that might be worsening memory, worsening thinking, and that can worsen psychosis. So these could be some bladder medications. Don't take them out on your own, discuss with your doctor, but some of them might increase the risk of hallucinations. And also your doctor might decide with you that it would be a good time to decrease your Parkinson's medications. Because Parkinson's medications at a higher dose might worsen the hallucinations and might induce them. So it might be a good trade-off to decrease the dose, to decrease the hallucinations without worsening your motor symptoms, which is like the tremor and the walking. And if nothing works in terms of these managements, then your doctor might recommend to add a medication to decrease the hallucination. The one that's FDA approved is called pimavanserin, but we use other types of agents like clozapine, quetiapine. We use the memory medications also to treat these hallucinations. There are some medications that are high risk and only used in cases where it is a very severe hallucinations that need immediate management. Now we're going to go from the cognitive changes to neuropsychiatric or mood changes. So depression is very common in Parkinson's disease. Around 30% of people with Parkinson's have depression. It is commonly associated with some form of cognitive change. Doesn't need to be dementia, but some form of cognitive change. And the treatment is very similar to treating any form of depression, but we know in Parkinson's disease that combining the talk therapy, so the CBT or the counseling, is very important to be combined with the medication treatment, because in addition to the reaction to having Parkinson's, making a person depressed. There's a chemical imbalance, a decrease in serotonin function in the brain that needs to be treated with medication. So usually combining the therapy with the medications works better in Parkinson's disease. Same thing with anxiety. It's quite common. They commonly come together, anxiety and depression in Parkinson's. And anxiety is important to treat because it can worsen symptoms, so it can worsen tremor, for example, or it can limit doing day-to-day activities, limit engagement because of fear of falling, for example, or because of fear of being outside with people or social embarrassment. So managing these symptoms can also improve quality of life and engagement with Parkinson's exercise. Another common mood symptom is apathy. Anybody has heard of apathy here before? Okay, so apathy can happen with depression, but it can be independent. Apathy means that the person has no motivation to do day-to-day things, so decreased interest. A person can look depressed, but if you ask them, they tell you, no, they're fine. They just don't want to move out of the chair. They don't want to go outside and then go to the park. And that's part of Parkinson's disease. That can create a lot of tension for the person as well as for their spouse because it can limit day-to-day activities. It is quite common in Parkinson's. It can even happen before the tremors and the motor functions occur. And the treatment is not clear. We usually treat it in a similar fashion. We treat depression as well as optimize the Parkinson's medications. This can be a little bit of a tough symptom to improve. Exercise can sometimes be helpful to create a regimen that is like almost a schedule where things are being done in a certain way, can improve apathy. But we don't have very good treatments at this point to manage apathy. Another thing you most likely heard your doctor mention at some point is impulse control disorders. So not common, they occur around 13% of people, and these can include pathologic gambling, hypersexuality, compulsive shopping, binge eating. There are other forms also, something called dopamine dysregulation syndrome. The person becomes almost addicted to their medicines. They take more, they hide medicines in the house. Punting, which is doing repetitive behavior for no aim. So like taking stuff out of the drawers and putting them back for no reason, collecting things for no reason, hoarding things, hobbyism, spending a long time doing one hobby, like spending 8 hours painting in the garage, and walkabouts, like aimlessly walking around in the house for no specific reason. These things are all something called impulse control disorder. They are part of Parkinson's, and they can be worsened by some of the medicines we give to treat the Parkinson's symptoms. So the first thing that your doctor would do is, in these cases, once we know about them, is to see if we can decrease your Parkinson's medications in a safe way to decrease them. Otherwise, we might need to add medications to help control some of these symptoms. Unfortunately, most of these symptoms go underreported. The person who's having them might not want to report them or might feel embarrassed to report them. So the caregiver here plays a very important role in alerting the healthcare provider about these symptoms and knowing about how they're progressing before they become more significant. So before, let's say, compulsive gambling become an issue and some people can go bankrupt because of the intensity of gambling. So it's very important to address this early on and avoid this complication. Another thing that's very common in Parkinson's is something called facial emotional recognition. So we all know that in Parkinson's disease there is decreased facial expression, something called poker face, but it goes both ways. The person who has Parkinson's has difficulty expressing their emotions spontaneously on their face, but also they have difficulty understanding other people's emotions on their face. They have difficulty reading people's faces, and especially negative emotions. So if another person in front of them is angry or upset, they might not realize that, and that can create some interpersonal difficulties. So being aware of that with Parkinson's can help decrease the risk of having interpersonal conflict because of difficulty understanding facial emotions. So this is some of the neuropsychiatric symptoms. Now for sleep problems, these are really common in Parkinson's disease. Depending on the study you're looking at, it can be up to almost everybody. 98% of people with Parkinson's can have some form of a sleep problem, and they can be many. So it can be insomnia, so difficulty staying asleep, falling asleep, or waking up too early. excessive daytime sleepiness, being too sleepy during the day, or sleep attacks, suddenly sleeping, nocturia, which is difficulty with going frequently to the bathroom at night, sleep apnea, restless leg syndrome, and then sleepwalking and acting up the dreams. These are all forms of sleep disturbances that can happen in Parkinson's disease. So insomnia can be worsened by multiple things. It can be worsened by some medications. It can also be worsened by mood problems and also worsened by fluctuations. So people sometimes might have insomnia, difficulty staying asleep because they get stiff in the middle of the night and they wake up because their muscles are tight and they cannot fall back asleep. Or they can wake up multiple times to go to the bathroom, or because of pain, or because of uncontrolled movements called dyskinesia. So whenever a sleep problem occurs in these situations, it's very important to try to find out if there's a reason specific that can be addressed and then improved. Another thing that's quite common is this REM sleep behavior disorder or acting up the dreams. You might hear something called RBD. These are, the person is asleep, they're dreaming, but rather than not moving, they will be moving and acting the dream. So that can usually induce punching, holding, kicking, falling off bed, kicking the spouse off the bed, or bruising the spouse. So it is important to make sure that these symptoms are discussed because they can be managed and improved with medications as well as some sleep changes. They're most common in the second half of the night, so from midnight to the morning. This is when most of these symptoms happen. So for management, there are certain things that can be done called sleep hygiene things, making sure you wind down by the end of the day, do relaxing activities, avoid stimulating substances like caffeine later in the day, and also doing exercise program on a regular basis can help encourage a good sleep cycle, as well as light therapy, especially in winter, which is expose yourself to bright light for 20 minutes or 30 minutes in the morning, can also help improve the sleep cycle. Now, for each one of these types of sleep problems, there are some medications that your doctor can try with you, and they can help some of these symptoms. So one, for example, for the acting up the dreams, one over-the-counter substance that we commonly try is melatonin, and that can help decrease the frequency of these symptoms from happening. Another symptom is fatigue. So fatigue is a little bit different than sleep. It's just the feeling of exhaustion, without being sleepy. And the most important thing when checking fatigue is making sure there's no other reason to explain the fatigue other than just Parkinson's disease. So it's very important to make sure that there's no depression, there's no heart failure, there's no kidney problem, there's no anemia. Low blood pressure sometimes can present as fatigue, so checking for other reasons is important. Now, if all the other reasons have been checked out, the treatment is also, in terms of medications, is very limited. We have some medications here that you can see their names, but they sometimes might not be recommended if there is heart disease problems. The most important thing is to create a regimen during the day, similar to apathy, create an exercise regimen, and then develop something called an energy expenditure plan. So think about you have this much energy a day, let's say 50 energy a day, and you're going to use them, and then by let's say 5 p.m., that's going to go away. So you know that you're going to do most of the activities that require most of the energy early in the day, and then leave the activities that need less physical energy, like reading or watching TV, till later during the day. And that way you can use your energy a bit better during the day, despite the fatigue that creeps in by the end of the day. So if these don't work, then as I said, there are some medications we can try, but they're not very effective. And this is another area where we need to develop better treatments for management in Parkinson's. Okay, now we're going to go to the cardiovascular autonomic symptoms. So these are the things that your body controls without your control, like your heart rate, your blood pressure, your sweating, your skin tone, which is if it's flushed or not. So one of the common symptoms of in Parkinson's is something called orthostatic hypertension, which is when you stand up, your blood pressure drops and you feel dizzy. But the dizziness is not the only symptom you might feel. You might just feel fatigued, or you might feel unsteady on your feet, or you might feel heaviness on the shoulders, or even sometimes chest pain that feels like a heart attack. So all of these can be symptoms of low blood pressure when you stand up. It is not a rare symptom. Up to 50% of people have it, but only 16% have symptoms that affect their day-to-day function. The medications that we use to treat Parkinson's disease, at least in the beginning when we start them, like when we start levodopa, your blood pressure can drop a little bit when you stand up. But as long as you continue taking it and it stays at the same dose, that effect decreases a little bit over time. But this problem is not just medication related, it is present as part of the Parkinson's disease itself. Now, in terms of treatment, there's a lot of stuff you can do on your own at home. It's very important to stay hydrated, especially in the summer. There's no magic number you need to drink, but the most accepted number is 2 to 2.5 liters of liquid a day. It's very important to avoid high sugar drinks because they decrease your blood pressure because of the chemical changes that happen, how the sugar gets absorbed. Also avoiding alcohol during the day because alcohol can decrease your blood pressure. The role of caffeine here is not very clear. There is studies both ways, whether caffeine helps or doesn't help. So check it for yourself and see if stop it and see if that makes it better or not. This is the only time you would go to a doctor's office and the doctor would tell you eat more salt. So it is good to eat because salt helps you retain water and help increase your blood pressure. So eating salty food like chips and pickles would be recommended. You can have salt tablets too, but these can give you stomach upset, so it might be easier to have salt with food otherwise. There's a trick that can work for some people, which is to drink a large cup of water, so half a liter of water before standing up, within 30 minutes of standing up. That can help your blood pressure stay a bit high for maybe an hour or two, so that can make your symptoms less severe when standing up. Other thing that's very important is to continue to exercise. Many people, once they start having dizziness when standing up, they stop exercising. And the reason for this is understandable. Like, you want to try to use the bike, you get dizzy, you're afraid of falling. But it's very important to adjust your exercise regimen and do recumbent exercise or swimming exercises if you can, because doing exercise helps maintain your blood pressure better than if you don't exercise. So the same thing, like when you drink high sugar drinks, having a large carbohydrate meal, like a big pasta dish, might also decrease your blood pressure, and it's better to eat small and frequently rather than to eat large when you have these types of symptoms. Sitting before standing and doing it slowly decreases the dizziness, and also treating constipation because straining a lot can also decrease blood pressure. Then the other thing you can do, which is very hard to use in Florida, is compression stockings, because there can be, because of the heat, they can become very hard to use them. But if you're going to use them, you have to get the high ones, the ones that reach the waist level. The ones to the knees don't work as well. They have to be 15 to 20 millimeters of pressure. And if this is too cumbersome, there is some studies that show using the abdominal binders, the ones that are used after stomach surgery, can also be helpful. Also, the pressure has to be around 20 to help decrease the dizziness symptoms. So if all of these things that you tried yourself at home didn't work, then your doctor will try with you some medications. So some medications can increase the amount of blood or the volume of blood in your blood vessels. One is called fludrocortisone, and others increase the tone of the blood vessels, so the blood vessels become narrower and then the blood pressure becomes higher. And the two FDA-approved ones are midodrine and droxidopa, but there are other agents that we can use. Now, the flip side is something called supine hypertension, which means that now the person is lying down, and rather than having normal or low blood pressure, they will have high blood pressure. And this is quite common, especially in people who have this orthostatic hypertension. And the medication we give you to help the blood pressure can make this problem worse. So it's very important, if you have orthostatic hypertension, not just to check your blood pressure sitting or standing, but also to check it lying down to make sure you don't have this problem. Now, the things I told you before not to do are maybe helpful here. So drinking alcohol, having a high carbohydrate meal before you go to sleep, can be helpful. I don't want you to be alcoholics, but if you want to have an alcoholic beverage, have it before you go to sleep, because that can help decrease the supine hypertension. And in very severe cases, your doctor would add a blood pressure medicine to take at night to control the high blood pressure. So you'll see here that at night you take a blood pressure to decrease your blood pressure. In the morning you take a blood pressure medicine to increase your blood pressure. So it can be a little bit of an adjustment game between the two extremes. Another thing that's quite common is perspiration or sweating. It can be up or down in Parkinson's. And then it can be related to fluctuations. Some people sweat mainly when their medications are wearing off. It can be also worsened by some dementia medications and can make the person sweat more, so it's important to review the medications. There's not a lot of good treatments to treat sweating if it is increased throughout the body. There's a medicine called glycopyrrolate, but that can make a person confused. You can try. Some people found it helpful to try to use sage extract, 100 milligrams twice a day, so it's effectively sage concentrate. That can, for some people, be helpful to control these symptoms. Now, in terms of urinary symptoms, these are also quite common. Some are expected with age, so it's important to see a urologist and make sure there's no structural problems, no prostate enlargement, no bladder prolapse, no other reasons for having the problems. And in Parkinson's disease, the most common reason for urine control issues is something called bladder hyperactivity. So the bladder contracts more than it should be, even if there is a tiny amount of urine in the bladder. But there are other reasons. So it's very important for your doctor to identify the reason for the symptoms, because the treatments are based on the reason for the treatment. Now, in terms of medications, there is only one that has been studied specifically in Parkinson's disease. You can see the name there at the end, solifenacine. But we use multiple other agents, even though they're not studied directly in Parkinson's disease, but studied in the general population. Now, there are certain behavioral things or things you can do at home to decrease the risk of urinary problems. So if you're going to the bathroom very frequently, creating a regular bathroom breaks, so going to the bathroom, even if you don't need to go to the bathroom every 2 hours or every hour, could be something that can help decrease the risk of accidents. Also decreasing fluid intake before you go to bed, so that you don't wake up multiple times at night. And other types of techniques that can be used to help, depending on the symptoms. It would be a good thing to discuss with your doctor to develop a certain strategy to help with these symptoms. Another thing is that people who have orthostatic hypertension have a tendency to pull blood in their legs during the day, and once they go to sleep, then all that blood rushes back, and then they have increased production of urine. So making sure that we treat this by using the compression stockings or lifting the legs can help decrease going to the bathroom frequently at night, for example. Okay, now we're going to go to the sexual dysfunction. This is something that both patients and doctors feel uncomfortable discussing most of the time, but it's important. It's quite common in Parkinson's disease. This is a survey of people with Parkinson's. 80% of men reported decreased libido and erectile dysfunction. 84% of women reported decreased libido, and 75% of women reported difficulty with reaching orgasm. So this is something that's very common, but very rarely discussed. But we know it's very important to have a happy and contented life, to have a good sexual life. So it is something that we as doctors are trying to bypass our discomfort to try to discuss with you more, but also it would be important for patients also to bring these symptoms up to their doctor too, because there are some treatments that are available for many of these symptoms in collaboration usually with a urologist to help a lot of these symptoms. Now the flip side is hypersexuality, which is quite rare, and that's part of the impulse control symptoms. So the most common dysfunction is a decrease in sexual drive, a decrease in sexual function rather than an increase. So the causes are multiple. They can be related to just the physical difficulties, rigidity, slowness, or cognitive or mood problems can be an issue. Also, they can be psychological problems where the person is afraid of being rejected by their partner because of their Parkinson's disease, or being very self-aware of their symptoms. And also, they have other problems that can happen, like diabetes, that can be another factor. So seeing a sex therapist, especially if there is psychological factors contributing to the sexual dysfunction, speaking with the doctor for medical treatments, and also sometimes using antidepressants, depending on the type of symptoms that the person has, can be helpful in controlling these symptoms. Okay, now moving to the stomach or the digestive tract. So almost all the parts of the digestive tract can be affected in Parkinson's, from the mouth, with dryness in the mouth, drooling, decreased taste, swallowing difficulties, and then the stomach, where you have slowness in the stomach, difficulty with digestion, causing weight loss, as well as constipation. So constipation was one of the first symptoms that was recognized by Dr. James Parkinson in 1817, when he described people with Parkinson's as having very severe difficulty with constipation, requiring sometimes mechanical aids. So it's very important to manage constipation in Parkinson's. Hydration is very important. Probiotics can be helpful, increasing fiber, but it's very important that when you add fiber, to make sure you're very well hydrated, because having fiber and not being very well hydrated would worsen your constipation and also worsen your digestion. Physical activity is important, and then changing the position to squatting position can be helpful to improve the bowel movements. These are some types of treatments that you can consider. Probiotics, something called bulk-producing agents, so like fibers. The other one you see here is with the fluid is like Miralax, where it can increase the amount of water inside the stools. Stimulate by Senna, for example, that can stimulate the intestines. And there are some medications that that your doctor would prescribe that can sometimes help. Some of them are studied in Parkinson's, most are not studied in Parkinson's, but your doctor would use anyways. Botox can sometimes be helpful in very specific situations. And there are some medicines that your doctor can ask the FDA for an exemption because they are not available in the United States. Now, the reason to treat constipation is not simply just to avoid bloating. The constipation can decrease the absorption of medications and can make the medication absorption erratic, which means not every time you take the medicines they would work. But also they can cause medical emergencies. These are the medical emergencies. There's something called volvulus, which is your intestine twists on itself. That's a medical emergency. You need to go to the emergency room. Another one is obstruction. Your bowels gets blocked, and you need to go to the emergency room to get it open. And the last one, which is the more serious one, is perforation. There's a leakage from the intestine into the cavity, and that can create a bad infection. A complication of constipation can be weight change, but weight change can happen without constipation. Weight change is very important. Weight is very important in Parkinson's, especially weight loss, because significant weight loss is associated with severe worsening of cognition, severe worsening of motor function, and fluctuations. So it's very important to keep track of weight and then ask nutritionists for help if that's not being stabilized. Now, what diet you should eat? There's no specific diet right now that we know that helps Parkinson's more than another. We know that high carbohydrate diets, low fat diets can improve levodopa absorption and can improve the amount of dopamine in your brain, but then high fat diets can improve how your body uses energy in Parkinson's. So they did a study recently in New Zealand where they had only 44 people and only for 8 weeks, and they divided them into two groups, one to eat a high carb diet and one to eat a high fat or ketogenic diet. Both of them tolerated it equally, but only for 8 weeks, so I'm not sure. And then the other thing is the ketogenic diet might have improved the non-motor symptoms a little bit better than the carbohydrate diet. But again, take this information with a big grain of salt because this is a very small study and only for 8 weeks. So there is some work being done to see if there's one diet that's better than another, but at this point it's not clear. We spoke about pain. It's quite common, and it's very important in Parkinson's to realize how much of this pain is related to the Parkinson's fluctuation and how much of it is related to other associated conditions like arthritis, nerve pain, that can all be increased and decreased because of Parkinson's disease itself. Other symptoms is osteoporosis is higher in Parkinson's than in other conditions, and also vision changes is a problem, especially difficulty with reading, having seen double vision because of difficulty with eye movement. So it can be really hard to read when you're seeing the text like that. So seeing an ophthalmologist, maybe having prisms that can help, can sometimes be helpful in improving reading in these cases. Now, in addition to the regular treatments, there are other treatments that can be helpful for non-motor symptoms. Dancing, for example, can improve cognition, apathy, and fatigue. Physical therapy can improve sleep, quality of life, fatigue, depression, apathy, and anxiety. Tai Chi and yoga can improve quality of life, and acupuncture can improve quality of sleep, depression, and sleep. So there are other things you can do that can help improve many of these symptoms. I know I'm running out of time, just a few more slides. This is, just watch this video, it's a bit fun. It's from the 90s, I always like it. I want to be that lady at some point. So, the driving of Parkinson's disease is very hard for your doctor to assess if you're a safe driver or not, because we cannot assess driving. Driving is more than simply seeing well and reacting quickly. But people with Parkinson's are at higher risk of difficulty with driving, and the best approach usually is to do a proper driver's evaluation, whether it is at the DMV or with an occupational therapist doing driver's evaluation. These could be good ways to evaluate driving difficulties in Parkinson's disease. Now, the last thing I'm going to speak about is something called the caregiver burden. Most people who live with Parkinson's disease, the rest of the family also helps them during that time. And it's very important to assess and realize this other part of the care team, not just focus on the patient and the doctor, but also remember that there's another person there also helping with this relationship. And studies have shown that people who take care of people with Parkinson's disease have a higher risk of having depression and have a higher risk of having medical complications like heart disease. So the caregiver is an important part of the care team for multiple reasons, and it's very important during a clinic visit for the caregiver to voice any concerns they might have and the doctor to address that in terms of services. So these are some excerpts from people who were caregivers, how they felt during these situations. But in terms, if we're going to go by these non-motor symptoms, if we consider executive function, which is the capacity to make complex decisions. So let's say the person who had Parkinson's was the person who used to make the finances at the house. And then they had Parkinson's, they developed dementia because of Parkinson's, and now they cannot take care of the finances. Now the person who didn't do them all their life now is going to take care of the family finances, and that can be a big burden on them. Psychosis, having hallucinations, can be a very big problem for the person living with a person with Parkinson's disease, because they have to make sure everybody's safe, and their sleep can be disrupted. Anxiety can affect the interpersonal relationships. Apathy can limit their capacity to interact with friends, can make them socially isolated, and that can also affect quality of life. Impulse control disorder can be a big problem. Fatigue, another problem. Sleep disturbances, as I mentioned, the acting up the dreams can be a big problem. People can end up sleeping in different bedrooms or different beds because of this issue. Urinary dysfunction affects mainly because of the frequent need for help or the frequent need to wake up in the middle of the night, and sexual dysfunction. So it's very important for the caregiver to discuss with the providers, and then also the provider to ask the questions about how the caregiver is doing, make sure that they have all the services they need. There are a lot of services that can give the caregiver a break. It's very important for the caregiver to have a break where they don't only do groceries and clean the house, but a break where they can have fun, go with their friends, at least once a week. So asking your doctor, they can connect you with social workers as well as counselors that can connect you with services that you can access to get these services and get the help that you need. Okay, so that's it, and thank you.